Hello, osteopathic physicians and surgeons of California. I am delighted to be joining you on this recorded presentation for our Osteopathic Physicians and Surgeons CME by the Bay 2021. My name is Jonathan Terry. I am a board-certified psychiatrist in the Fresno area. In California, I teach with California Health Sciences University and Touro University, and I'm also a course director for the St. Agnes residency programs right here in scenic Fresno. Today, I have a challenging job, but not an impossible job, in that I am going to share with you a thriller review of extrapyramidal symptoms, specifically for 2021. You heard that right, and you might recognize this young man on screen, the late Michael Jackson, who is going to be assisting us today with teaching us about movement disorders as they apply to our understanding of them in 2021. A lot has changed since the way that I learned about these in medical school and residency, and I'm going to update you and bring it all together. Now, for those of you who might have seen Michael Jackson's Thriller music video. The video came out in 1982. It's over 15 minutes long. It's really an incredible time capsule. Really, Michael Jackson can teach us so much about mental health and many things. But Michael started his video with this quote: "Due to my strong personal convictions, I wish to stress that this film in no way endorses a belief in the occult." Now, similarly, I want to start my presentation by saying that by using Michael Jackson and his Thriller music video to teach us about this topic, this is not meant to make light of or disparage anyone who might be experiencing these movement disorders or extrapyramidal symptoms, but rather to come up with a paradigm and a mechanism that you and I can internalize this topic and realize how it applies to our clinical practice. I'm going to specify as well, before starting this talk, before we go into our objectives in the next slide, that this is a talk, even though I'm a psychiatrist, we are going to be talking very much about primary care topics and about why this topic is relevant for all of us in the room today. If we look at my learning objectives, I have 5 topics that I want to discuss with you today. First, we're going to compare and contrast the common movement disorders from many dopamine blocking medications, many of which are not antipsychotics. In our second objective, we're going to synthesize the risk factors and epidemiology for extrapyramidal symptoms as they might be relevant for your patient population. We're going to learn to evaluate patients for acute and tardive dyskinesias using the Abnormal Involuntary Movement Scale, or AIMS. Then we're going to take our patients and dive into the cell a little bit further to look at the physiology, the functional anatomy that underlies these drug-induced and drug-exacerbated movement disorders. And finally, we're going to take a look at these relatively new medications that were approved in 2017, the VMAT2 inhibitors, and tell you why what our understanding is of tardive dyskinesias is so much different than what you or I might have learned in residency in med school, and why we have such better tools now than we've ever had before. Without further ado, let's dive in. I'm going to take on these first 2 learning objectives together. First, we are going to compare and contrast common movement disorders from, again, these increasingly common dopamine blocking medications. Then, we're going to synthesize the risk factors and epidemiology for extrapyramidal symptoms as is relevant for the patients that you and I see. Now, let's bring us back to Thriller. If we were to look at this cast, arguably, if we were to say, okay, who's in the Thriller music video? A lot of us, those of us who have seen the video, might be able to say, hey, there was this guy, Michael Jackson. It was kind of earlier in his career. He's definitely in the Thriller video. Similarly, if I were to ask you, what types of medications cause extrapyramidal symptoms or an acute dyskinesia or tardive dyskinesia, you might be able to say antipsychotics. So I'm going to name that, put the elephant in the room, the one we can all name and recognize. I'm here to remind you that any medication that affects dopaminergic transmission can cause these extrapyramidal symptoms. So if we look at some of these other cast members here in our music video, we've got lithium, selective serotonin reuptake inhibitors, SSRIs, our tricyclic antidepressants, or TCAs, valproic acid, or Depakote, stimulant medicines, antiemetics, One of the most common presentations that I see in my primary care patients is people developing extrapyramidal symptoms in response to metoclopramide or Reglan that they might be taking for diabetic gastroparesis. Even our antihistamines can be associated with extrapyramidal symptoms. So as I'm going through this talk, as a psychiatrist, of course, I'm thinking about antipsychotics. That's my turf. That's what I know about. That's my jam. We're going to be spending some time, though, thinking about all of these other medicines that we use all the time in our primary care and other settings. Now, if we were to take a look at the wide range of movement disorders from our dopamine blocking medications, these top two categories that I have here, the acute dyskinesias and the tardive dyskinesias, might be the ones that we know the most about. And I'm going to spend some time on the next couple of slides giving you way more details about both acute and tardive dyskinesias. One quick note, for those of you who are Doctor Who fans, I just want to emphasize this is the Michael Jackson talk. So if you're planning on thinking about the TARDIS, that is in another talk. Now, we can also talk about Parkinsonism. We can talk about neuroleptic malignant syndrome, a board question favorite. And we can talk about withdrawal emergent dyskinesias, when you're removing the offending agent and the symptoms get worse. So as we think about these, the first thing that I'm going to do is I'm going to take us into a discussion of the acute dyskinesias. Now, when you think about acute dyskinesias, you might not be picturing this patient that I see here from the journal Neurology, from one of their video segments. Now, this patient, I'm going to play this video for you, and I want you to observe what's going on with her movements. Now, some of you might immediately be noticing, hey, something's going on with her eyes. And if you were to say, wow, that looks like an oculogyric crisis, you are correct. You can skip the rest of this talk. However, there's more going on here as well. You might notice that she also has a left-sided torticollis where her sternocleidomastoid is tight here. She also has some oral buccal movements that are occurring as well. And these movements are bothering her. It might look like she's smiling in this video, but I promise you she's not. It's more of a grimace. It's more of discomfort that's coming from not being able to move one's eyes, not being able to move one's jaw. A lot of the problems that we see here in this video. I'm going to leave this video up, let it play again, just so you can take a closer look at the symptoms. Again, this isn't a 10-year-old girl. And the reason that she's having these symptoms, again, was not related to antipsychotic medicines. However, let me give you some overview so that you can recognize acute dyskinesias. I warn you, this slide and the next one are two of my wordiest slides in this whole presentation. The reason I did this is so that you'll have a reference for later, but I don't necessarily expect you to read along with this information. So how do we differentiate an acute dyskinesia? An acute dyskinesia will develop within days, often, of initiating or increasing a dose of a medication, but here's the cool part. It will spontaneously subside in response to decreasing its dose or on its own. So if there's a dose reduction, or if we just wait, an acute dyskinesia often will resolve on its own. Now here I have listed several of the types of acute dyskinesias, and there are a number of them. Akathisia, or subjective sense of restlessness, could be considered a type of dyskinesia. Dystonic postures of the limbs or trunk, repetitive jaw and facial muscle contractions, tongue protrusion, torticollis, right? We saw some of these in the video. Oculogyric crisis, that feeling of the eyes rolling back and not being able to write them, and Parkinsonism. Now, one of the things I want to warn you on is our adolescents and young adults are much more susceptible to these, which makes it really interesting when we remember our medication classes, things like stimulants, things like antihistamines, things like antiemetics. All of these can cause these symptoms, especially in our adolescents and young adults. Our adolescents and young adults are also more likely to suffer severe reactions, especially males. Now, here's something really interesting in that if we think about our dyskinesias as aberrancies in the dopamine system, any abuse, so to speak, that the dopamine system has endured before is also going to result in these types of symptoms or worsen the risk of a patient developing them. So if you have somebody who's used cocaine or somebody who's used methamphetamine, which might describe one or two of our patients. Those types of stimulant abuse do place an individual at up to a 40-fold increased risk of developing these acute dyskinesias. Now, why do these things happen? Well, it's mostly theoretical. There are a couple of theories, one being that excessive cholinergic activity may be at play, especially as we think about the acetylcholine system balancing out our dopaminergic system. That might be one of the reasons why anticholinergics, which we'll talk about later, things like benztropine, are great for treating acute dyskinesias. There's another possibility that brief overstimulation of the dopamine receptor by neuroleptics or by some of our dopamine blocking medications leave receptors transiently exposed, perhaps oversensitive, perhaps upregulated. I'm going to show you a picture of what that looks like later, and we're going to show you the specific parts in the brain where those things occur. So I want you to keep in mind these ideas about acute dyskinesias, and we're going to distinguish these from our tardive dyskinesias. Now, tardive means late, right? Some of us might have been perhaps tardy to a class once or twice in our lives. Now, the tardive dyskinesias, in contrast to our acute dyskinesias, these are going to develop 3 to 6 months after the onset of treatment, right? So this is not hours to days, this is often months, and these ones rarely subside spontaneously, again, in contrast to what we were just talking about. Our tardive dyskinesias are very resistant to treatment. In fact, when I was in residency, we didn't have any treatments for tardive dyskinesia. It was considered a permanent condition. So you might be thinking to yourself, okay, it's a movement disorder, whatever. I need to treat the gastroparesis. I need to treat the psychosis. I need to treat the mood disorder. I need to treat the ADHD or the narcolepsy. We use these medicines for reasons, right? Now, the other side of it that I want to present is that tardive dyskinesias can be incredibly disabling for the patients who have them. You can imagine, for example, a person who has tardive and permanent conditions affecting their eyes, much like we saw in the 10-year-old girl in the last video. You might be able to think of the patient who, I have some very high functioning patients who have developed these things. Say an attorney who's trying to present a case in court, and that attorney can't present her documents to the witness because her hand is shaking too much. For your patient who's already being stigmatized, say, for example, due to housing insecurity, or they might be riding a subway or pushing a shopping cart, what that might look like in public places with a person who has movements of their mouth, of their lips, of their tongue, of their trunk. We might think back to patients that we know with Huntington type chorea and how noticeable that is, and the way that the general public, who might not know and understand the ways they might react to a person with these movement disorders. So of these movement disorders, the most frequently occurring, and the one that many of us are familiar with, is this oral buccal lingual dyskinesia. That's the lip smacking, movements of the tongue, jaw, lower face, chewing, eye blinking. All of those things are symptoms that we commonly see. If we were to look at perhaps the videos that we've seen of tardive dyskinesia, that's what we see. Now, the risk factors for tardive dyskinesia, likewise, are different than those we talked about with our acute dyskinesias. Risk factors for tardive dyskinesia include a past history of any type of extrapyramidal symptoms. So hear that. A person who had an acute dyskinesia is now at risk of developing tardive dyskinesias. There's some evidence to suggest female gender may be at higher risk. Individuals greater than 65 years old. So important if you're thinking about using antipsychotic medicines in the elderly or any other medicines that we spoke about. Long-term treatment with antipsychotics or dopamine blocking medications. The use of typical or first-generation antipsychotics are associated with more of these symptoms than our second-generation ones. If antipsychotics are administered at a high dose, I think of some of my correctional work, working with prisoners, with violent offenders, with inmates on tremendous doses of antipsychotics and such a high risk of developing these symptoms. Alcohol abuse, and my favorite one, perhaps to remember, anticholinergic administration. Now, you may recall, what do we use for treatment of acute dyskinesias? If you said an anticholinergic, you're right. So for your patient who has been, for example, on long-term benztropine, long-term diphenhydramine, and they've never had that medicine attempted to be tapered, we might be doing our patients a favor to see if we can use less of that medicine. Of our antipsychotics, interestingly, one of our most robust antipsychotics, clozapine, associated with common board questions of agranulocytosis as a potential side effect, clozapine has very little risk relatively for extrapyramidal symptoms. One of the reasons for that, perhaps, is that it has relatively very little affinity for the dopamine 2 receptor. Now, for a patient who started on some type of dopamine blocking medication, how likely is that patient to develop some type of tardive dyskinesia? Interestingly, the risk is mostly linear, and it's about 5% per year. So what that means is that in that first year of treatment with whatever the medicine might be, there's about a 5% risk. Now, once they have it for 2 years, there's about a 10% risk that they will have developed some type of tardive dyskinesia. Once you get up to 5 years of treatment, and many of our patients take one of the medications or more for more than 5 years, there's a 25% risk that they're going to have tardive dyskinesia. If you do the math, after about 20 years, it's pretty much guaranteed that some type of tardive dyskinesia will develop. So if you see somebody in their 40s who was diagnosed, say, with schizophrenia in their 20s, you should be very vigilant about these tardive dyskinesias. I'll show you how to do that and consider treatment if you see one. Now, interestingly, the tardive dyskinesia, that late dyskinesia, it often will persist after medications are stopped, but there may be minor improvements over time, or if you switch to perhaps a less offensive agent. So it's a lot to think about. Now, I promised you that we weren't just going to be doctors. We weren't just going to focus on acute and tardive dyskinesias, but we were also going to have a thriller time learning these things together. So I'm going to show you just over a minute of the thriller music video. And what I want you to do as we're watching this video is I want you to look for the different types of dyskinesia that I've mentioned. You might see acute dyskinesias. You might see tardive dyskinesias. You might see some stereotype behaviors, tongue protrusions, oculogyrate crisis, oral buccal movements, trunk movements, you name it. I want you to keep an eye out for those symptoms as we're watching Thriller together. And now, if you do want to dance, I am not going to stop you for dancing, especially if my audio ends up working in this recording. All right, guys, let's go ahead. Let's watch some Thriller. All right, who saw some extrapyramidal symptoms? Did anybody spot maybe a little bit of akathisia? How about some bradykinesia? It's tough to test for cogwheeling on screen. Maybe there was some of that going on. Maybe some stereotype movements of the lips and face. Definitely some trunk movements. When I'm doing this exercise with my residents, I like to have them watch and they'll do the examination, the Ames examination that we're going to have later, actually in our next step. So let's take a dive here. Coming back to our learning objectives. So what we've done so far, we have compared and contrasted these common movement disorders, again, from dopamine blocking medications. And I want to move us on from that paradigm of it's not just antipsychotics, but there are so many potential risk factors here. We talked about the risk factors and the epidemiology. Who gets these symptoms? What are the risks? And now we are going to take a look at our last, sorry for my slide issues right here. We are going to take a look at the Ames scale, evaluating patients for acute and tardive dyskinesias using the abnormal involuntary movement scale. So again, our next slide that we are going to go to is going to have really small print, but stick with me. I'm going to walk you through this and we are going to do this together. So if you're in your seats, if you're at home watching the recording of this, you can do this with me. If you're seated in an audience today watching this video, we can go ahead and do this together. We are going to do an Ames together. So on the right side of the screen is the abnormal involuntary movement scale. And this is a public domain scale. It takes about 5 minutes to administer. And this is specifically designed for assessing for acute and tardive dyskinesias. Now, what this has is it has 12 questions that we're responsible for answering. And these questions are in different categories. There's facial and oral movements. There's extremity movements, trunk movements. Those ones are all for your observation. And then there's also these global judgments where you're making some decisions about the severity of the movements, how incapacitated the patient may be, the patient's awareness of abnormal movements. And that one sometimes surprises me. You would be amazed how many people have severe movements and have no idea they're happening, as well as dental status. Now, why do we have something about dental status? Well, if you can picture your person who has grinding of the teeth, not just bruxism, but the type of bruxism that occurs in tardive dyskinesia, or if they're a person who has dentures, this might be a person whose nutritional intake, whose ability to eat is severely impacted as a result of having tardive dyskinesia. It's also, if you have somebody with tardive dyskinesia, they're going to be going through their dentures left and right and breaking them and having dentures that don't fit and possibly injuring their underlying bony structures until we treat the tardive dyskinesia. Now, as we're going through this, the rating scales, for the most part, go from 1 to 5. Let me tell you a little bit about how that's rated. And fortunately, if you forget, it's mostly included up on the scale itself. But a 1 is going to be no movements at all. You don't notice a thing. 2 is going to be maybe they have them, maybe they don't. It might be normal. And it's actually really common for people who don't have tardive dyskinesia to have several 2s on their evaluation, right? For example, if I were to do some of the maneuvers, and you'll see me do them here in this recording, a 2 is totally expected. Some of us will have them. Now, 3 is where things start to get a little bit abnormal. 3 might be, it's recorded as mild symptoms, but that's where things only perhaps to a trained eye, you might say, okay, there is something there and it's more likely that it's there than not. Say 51%, this is definitely, abnormal. 4 is considered moderate, where even to the untrained eye, you'd be able to notice it. And 5 is severe, where if you've got this person who's on public transportation away from you, if they're sitting across from you in Monterey, if they're on the subway, even a person across the room or across a parking lot would be able to see those symptoms. So let's run through this. And this first step you don't have to do, but we're going to ask the patient to remove his or her shoes and socks. Why do we ask them to remove shoes and socks? Well, it's not just so you can get a good look at their feet, because honestly, we should all probably be looking at our patient's feet a bit more, but also you're going to be observing them while they are taking off their shoes and socks. Can they manage the gross motor movements and the fine motor movements that are necessary to take off a sock or untie a shoe? Once they do that, you're going to ask the patient, is there anything in your mouth? Do you have gum, candy, chewing tobacco? If there is, take it out, put it somewhere else. Be prepared to catch that and have a receptacle available. Again, we're watching the patient as they're going through things that a person would be expected to do, manipulating things in the facial area. Can they do that without interruption? Then we're going to ask the patient about the current condition of his or her teeth. Do they wear dentures? And do those dentures, if they do wear them, bother them? Do they fit okay? These are all things that are going to inform our eventual assessment. Then you're going to ask the patient, do you notice any movements in your mouth, face, hands, or feet? And if they do notice movements, to what extent do they currently bother the patient, or do they interfere with his or her activities? That's where a lot of the discussion, the general observation that comes on the scale is going to be derived from those initial questions. Now, the next set of things that we're going to do is where we are going to start sort of provoking the movements. And again, you can participate in these with me as we do them. So we are going to have the patient, and again, you can be the patient here, sit in the chair, hands on the knees, legs slightly apart, feet flat on the floor. And as the patient's in that position, we're going to be looking up and down, looking at the body, using our osteopathic skills of observation and inspection to see what's going on. See if anything is going on as they just sit with their hands on their knees. Some things to pick up here. Then you might notice a gentle pill rolling tremor, perhaps with Parkinsonism. You might notice some foot tapping. You might start noticing oral movements. So the key is to watch the whole person if you're doing this. Now, if you're doing telemedicine visits, if you're seeing the patient on their phone, one of the things I'll tell them to do, if the patient can, is to take the phone and see if they can get somebody else to hold it for them far away, like they're getting an awesome selfie. And what you want to see is the patient's head to toe so you can assess it. For example, the way that I'm seated right now in my tiny square on screen, you can only really see the upper part of my trunk, and that's not enough to do this evaluation. So if you are doing telemedicine, again, you want to see the whole person. Going back to our examination, we had the patient with their hands on their knees, legs slightly apart, feet flat on the floor. Once we finish that, you're going to have the patient move to have the hands kind of unsupported. If they are wearing pants or shorts, they can kind of rest them between their legs. If the person's wearing a dress or something that would interfere with that, you can have the arms just hang off by the side. So we can go ahead and practice that general motion. What we're doing here, while the arms are resting at the side, is again, we're watching that whole person. We're seeing, is anything moving that's not supposed to be moving? And if it is moving, is it a couple isolated movements as they're adjusting? Or is there more of a steady rhythmic type movement as we might expect with tardive dyskinesia? Now here comes the fun part, especially for those of you in person. We are going to ask the patient then, while they're seated comfortably, to open the mouth. Open and close it twice. Let's go ahead and do that. Now, as they're opening and closing their mouth twice, you're watching the mouth, you're watching the lips, you're watching the tongue at rest within the mouth. You don't have to tell the patient what you're watching, but you do want him or her to go through these motions and as you're observing. Now, after opening and closing the mouth twice, the next step is to protrude the tongue. And they're going to do this twice. Now, I like to look at tongue protrusions two different ways. I like to look at sort of a straightforward protrusion with using the tongue muscles. And I also like to have them hang the tongue so that it's just relaxed. I hope you're doing this with me. This is a great time to look at your neighbor and just say, perhaps, see if your neighbor can do the aims on you. If you're doing this in person. If you're wearing masks, that can make for an even more interesting interview right now. But as you get the idea, we're looking at tongue protrusions. We're looking at, the tongue when it's relaxed. We're seeing what's going on with that tongue. The tongue can be one of the most sensitive places to pick up on early tardive dyskinesias. Now, what you're going to do, and I'll sometimes do this if I do have a suspicion, I'll ask the patient to keep their tongue out and do this next part, which is basically to do rapid alternating movements of tapping the finger to the thumb and doing that as rapidly as possible with each hand for 10 to 15 seconds. See if they can go both directions. So you might end up with a person who has their tongue out and they're going. I usually have my patients, I tell them, don't do this when you're riding the bus or the subway back to home. Just do this one in the office. So we're going to do those rapid alternating movements with both hands. Again, you're observing and seeing if there's anything moving when it's not supposed to be moving. The next thing you're going to do is to flex and extend both the right and the left arms. See if you can get it through passive range of motion. Now, when I'm doing this, I like to take my thumb and place it right on that bicipital tendon. And then I will passively flex the patient's arm and extend it. I'll tell them, relax your arm, relax your arm. I'm going to flex and extend it. And you might feel little jumps in that bicipital tendon. For those of you who have ever felt cogwheeling, this is one of the most sensitive places to pick up on cogwheeling in early Parkinsonism. And that's a place where you might, again, notice these side effects before anyone else does. And once you feel that, bring over everybody who's learning with you, because it's so important for every physician to feel cogwheeling in his or her career. After doing the flexion and extension of the arms, we're going to ask the patient to stand up. If you want to stand up and stretch, here's a chance for you to do so. Rotate. Have the patient show you their right side. Have them show you their left side. See if there's any change, again, in their trunk, in their hips as they're moving. As the patient's standing, or if they need to sit, this can be done either way. You're going to have them extend both arms in front of them with palms down. And while you're doing this distraction technique of the palms out in front, you're going to be observing the trunk. You're going to be watching the feet. You're going to be watching the mouth again. As we do this distraction technique, the AIMS is a great exam because you're watching the entire body, even though we're doing these focused assessments. Then we're going to observe the gait. Have the patient walk a few paces. If we're in an exam room, I'll say, walk to the door and come back. If they have their family member taking the video and helping you out for your video visit, I'll say, hey, can you walk across the room and walk back? That sort of thing. This took, for us to do this took a little bit of time as I'm explaining this to you. But once you get comfortable with it, once you run through the aims, it's very quick. It's easy to integrate. And if you have somebody on a dopamine blocking medication, if you're starting a dopamine blocking medication, I would recommend this evaluation. Standard of care would be considered before initiation of the dopamine blocking medication if you can, and every 6 months. Now, of course, it's unreasonable. Let's say you're an emergency room physician and you have somebody, with acute emesis and you want to treat that. Now, of course, you're not necessarily going to administer this exam while they're nauseous and vomiting, right? But you want to do it as soon as possible to make sure you're protected and that the patient is protected perhaps from developing these symptoms. Now, the aims is so important. And because of that, as I mentioned, we really set a whole learning objective to talking about that. So as I take us through this talk and trying to put all of these concepts together for us, we talked about the moving disorders, the medications that cause them, the risk factors and epidemiology for why some patients might be higher risk than others. And we talked about, again, how to go ahead and use that aims. So this brings us to our next step here, where we've been talking a lot about patients, we've been talking about Michael Jackson, we've covered a lot of interesting topics today, but I want to talk with you about the physiology and the functional anatomy for what's going on behind these drug-induced and drug-exacerbated movement disorders. So for those of you who have been missing cell biology and physiology, we are going to take a deep dive into the cell. And what I want to show you here is these 3 different neurons. And this is step 1 on the top left, step 2 on the right, and step 3 down below. Now, what they're using in this example here, this is a normal cell that's not exposed to any dopamine blocking medication here on the left. And we see dopamine here in the presynaptic neuron. We see dopamine receptors in the postsynaptic neuron. And these dopamine vesicles, they kind of hit the cell membrane and the dopamine goes into the synapse. It binds the receptors and activates the postsynaptic neuron. We can all agree on that. Now, in this next image, we're going to look at a dopamine blocking medication. For our purposes, we're going to use haloperidol. Now, haloperidol goes in to the same cell, to these same cells, to these same neurons, and it's going to block some of these dopamine receptors, which is great if we believe that dopamine is one of the causes, if excess dopamine might be one of the causes for agitation, for hallucinations, those types of things. It's great to have some haloperidol. Perhaps we're blocking those or any other dopamine blocking medication. Now, interestingly, what happens in our third scene here is after a person has been on, say, a medication like haloperidol or another dopamine blocking medication for a long time. And what happens is we actually see more dopamine receptors than we had in the original cell. Here we just had the 1, 2, 3 receptors. Over time, we might see some upregulation of postsynaptic receptors, but we might think about these postsynaptic receptors perhaps as being a little bit more sensitive, maybe a little bit more, frizzled wires, if you will. And if there's any strayed dopamine in the synapse, it might bind to that new postsynaptic receptor and cause additional problems. One of the things that we can sort of associate with these movements is that they do resemble the movements that are caused by excess dopamine. Therefore, anything that might increase dopaminergic transmission. So again, we were blocking dopamine. Anytime you increase dopamine, it could cause things to get a little bit worse. And that could include reducing the medication dosage, stopping the medication, or if we were doing, different physiologic studies, adding a dopamine agonist like L-Dopa would have the same effect. And that's where we need to be careful. If we are withdrawing medicines, we want to do it very, very carefully and very slowly to allow the system time to adjust and react. There are other theories, again, for extrapyramidal symptoms. Some include abnormal GABA activity in the striatum. Others look at glutamate excitotoxicity and NMDA receptors. These are all possible and they could all be related. This is one way to think about it, and it's particularly useful for once I tell you how our VMAT2 inhibitors work when we get to those. So this is what's going on in the individual cell. Now, let's take a look at the brain itself. And what we have here is this really nice sagittal slice. We'll take a look at a coronal diagram here in a minute, but I want to remind you, and this may be a little bit traumatic for some of us, but I want to remind you of the at least 4 common dopamine pathways in the brain. And we're going to be taking a really close look at this pathway right here, this top pathway, that's the nigrostriatal dopamine pathway. And that pathway, as the name implies, goes from the substantia nigra, which we may remember is highly implicated in the pathology of Parkinsonism due to dopaminergic problems there, and the substantia nigra, which projects up into the basal ganglia. Now, one of the other problems, if you will, forgive me, when we're thinking about antipsychotics in particular, we might be thinking about the second pathway here, the mesolimbic pathway. And the mesolimbic pathway, we think, as it goes from the midbrain ventral tegmental area into the nucleus accumbens, part of the limbic system associated with many behaviors, such as pleasurable sensations, euphoric effects, drugs of abuse, remembering our talk about cocaine and amphetamine before, as well as delusions, hallucinations, possibly even some of the things related to our sense of balance and things like nausea for our antiemetics. So much going on in these dopamine systems. What I want to get at here is that when we use a dopamine blocking medication, our medications for the most part are not good enough to target just specific symptoms or just specific areas. So if I use a dopamine blocking medication in a patient, it may affect all of these different areas in terms of reducing dopamine transmission. On the slide, I do have an additional box just for your handout. If you do want some more information about this, if brain anatomy and dopamine pathways is something that brings up positive memories for you. Now, this is a different way of looking at the system here. And what we have here actually is a coronal slice going through this part here of sort of the thalamus and the extrapyramidal tract. Extrapyramidal symptoms are so named because they cross the pyramids in the medulla, the medullary pyramids. The extrapyramidal tract in general is going to start in the basal ganglia. Here we do have, if we zoom in on this section of this coronal slice, we're reminded about the substantia nigra that we were looking at here for the nigrostriatal pathway, and all of the different dopaminergic pathways that seem to come away from the substantia nigra, as well as the feedback mechanisms here. Don't worry, this specific thing will not be on the test. But what I want you to focus on is how the substantia nigra is so important for synthesis of dopamine and how that is going to affect all of these different pathways, not just through the nigrostriatal path, but also, as we mentioned, through that mesolimbic path. So any areas that we are affecting and blocking dopamine, we also risk causing movement disorders because we are affecting some of the very small, delicate, fragile systems that are responsible for our fine motor movements as well as our more gross motor inhibition. This in itself could be an entire talk on the neurology side of things. I'm going to be brief here and just say that, hey, for those of you interested in looking at our anatomy and physiology, here it is for you. For those of you who have lost, I want to bring us back to Michael Jackson. I want to bring us back to Thriller, because even though this topic can be a little bit unsettling and can be a little bit dry, this is Thriller. Now, coming back to our objectives, folks, we are in the home stretch. We've covered a lot of what we wanted to talk about today. We talked about the movement disorders, how to differentiate them. We talked about dopamine blocking medications beyond just antipsychotics. I gave you risk factors, epidemiology, for talking about those extrapyramidal symptoms and how they might apply to your patients. We've talked about the AIMS scale and how easy that is to do and how fun it is to do, and what a great thing to have your med students and residents get practice with. We also talked about the physiology and that functional anatomy behind the drug-induced movement disorders. Now, the very last thing that I have for you today is I want to talk about our newer VMAT2 inhibitors, as we might be able to treat tardive dyskinesia and contrast them from the agents used in acute dyskinesias. Next slide has a lot of words on it. I'm going to try to highlight your attention to specific areas. So as we look at these specific treatment options. I have it divided here in this chart between the acute dyskinesias, right? Those are the ones that develop in hours to days. And these are going to be things that we know about. We talked about benztropine. We know about diphenhydramine or Benadryl. Some of us might be familiar with trihexyphenidyl or Artane. We tend to use a little bit less of that one due to the potential for abuse. Now, we also want to pay attention to our tardive dyskinesias. Now, when I was in residency, I didn't have any of these bolded options, which now have level A reproducible evidence. There's deutetrabenazine and valbenazine, both actually developed from agents that historically were used for treating Huntington-type chorea. Now, deutetrabenazine and valbenazine, as you know, they received their FDA approval in 2017 for treatment of drug-induced tardive dyskinesia. So if you can diagnose that, you can now treat it. For your patient who is having trouble with their dentures, with their movements, with being able to do their job, with being able to hold their pen in their classes, with being able to type, with being able to take an order at Starbucks, whatever their tardive dyskinesias are interfering with, we have treatments that are highly effective. Now, I was looking for some videos to show you how effective these were. And interestingly, I couldn't find good options that weren't linked to industry. So you're going to have to take my word for it. And if you want to take a look at some of the promotional videos, because again, these are pretty new medicines. It's amazing seeing within 24 hours, patients who have tardive dyskinesia for decades, suddenly they're not having the movements or their movements are reduced. It's the similar joy perhaps to some of us have seen the videos with deep brain stimulation for severe seizures or for Parkinson's disease. The way that those effects are immediate for things that when I was in school were considered permanent and untreatable. Now, I have some other things on this list here because these are the things, the options that I did have when I was a resident. If a patient had tardive dyskinesia, I could gradually reduce the dose and yeah, maybe the symptoms might improve a little bit. Clonazepam has some level B evidence. We used a lot of that, but in many of our patients, we don't want to prescribe benzodiazepines, and those have class risks if we're using them for a long time as well. Now, there are a number of other options here. Botulism toxin, acetazolamide, spelled incorrectly, baclofen, levetiracetam, vitamins B6 and E, zonisamide, zolpidem, even ECT. Each of these things are topics that, for example, might be familiar to me on my specialty board exam, but they're things that in general don't have the best evidence. We do have some anecdotal case studies and sort of retrospective cohort type studies talking about each of these. And I think I neglected to mention amantadine. All kind of low evidence. So if one does have the option, especially because we do have these newer agents, I want you to be familiar with them. And again, it would be a lecture in itself to talk with you about each of these agents, to talk with you about how to use them. For this talk, which appeals to many specialties, I'm not going to go into that level of detail, but I want you to be aware that they are available. And if you do see a patient with tardive dyskinesia, you can look into treating this yourself. It's very easy to treat. It's very safe and effective to use these medicines, or refer them to a neurologist, refer them to a psychiatrist. I will be happy to treat the tardive dyskinesia that you pick up on your patients using our thriller skills that we've worked on together. Now, I showed you a cell before. I'm going to show you a different cell here. Maybe that's a lie. It's the same cell. But again, we have our normal cell here with presynaptic dopamine vesicles that move to the membrane and bring dopamine to the synapse and eventually the postsynaptic neuron. Here's where we have a blockade due to a dopamine blocking medication. What I'm going to do is I am designating a VMAT2 inhibitor or a vesicular monoamine transporter 2 inhibitor as a medication that can block the presynaptic proteins that package and release this dopamine right here. So what this VMAT2 is doing, I've used an anchor symbol here to demonstrate that this is going to anchor that dopamine in the presynaptic neuron so that it doesn't spill over and cause those extra signals from stray dopamine that's associated with our movement disorders. So again, let's take a look. The anchor comes in as our VMAT2 inhibitor. Just like that, it really spins in real life. And what it's going to do, again, is it is going to block those presynaptic proteins that package and release dopamine and other monoamines so that that dopamine that would cross the synapse never arrives. So we don't notice the same type of aberrant motions and that extra signal because that VMAT2 inhibitor is going in and slowing down the process. One of the coolest things about our VMAT2 inhibitors is you can go ahead and continue them along with whatever the dopamine blocking medication is. So if I have a patient who's got excellent control, say on his or her antipsychotic, I don't have to decrease the dose if that is the lowest effective dose that serves them. I could prescribe a VMAT2 inhibitor that instead is going to treat their tardive dyskinesia while allowing them to continue their dose. These medications, we do have a long track record of using them again in Huntington type chorea. We are seeing much more of them though with this additional indication. We've had the indication for about 4 years, so it's still pretty new in the world of medicine for this indication, but it's something that I am really excited about again, because this takes something that is profoundly disabling for the patient it affects, and it gives you a treatment that is available, mostly accessible, still a bit expensive or might require prior authorization, but with great options available from the companies that produce these medicines for having these things be accessible to our patients, including our patients with who are Medicare or Medi-Cal beneficiaries. So in this talk, we have covered a lot of ground, and I hope it has been as thriller for you as it has been for me. Taking a look once more at our, so again, the net effect, less stray dopamine in the synapse. Just want to make that point. That's what we're doing here. If we take a look back at our learning objectives, we have covered so much here. We've covered the movement disorders themselves. I've gone into a review that I hope would hold its own for any of you who might be taking boards or recertification exams sometime soon. We've covered the dopamine blocking medications. So if you in your practice see a patient, say who is on not an antipsychotic, but maybe an antiemetic, maybe in some cases an antiparasitic, maybe an antihistamine, maybe an anticholinergic, and you notice a movement disorder, I want you to be thinking about this talk and maybe practicing your Michael Jackson dancing. I want you to know how to synthesize and thinking about these risk factors, the epidemiology for who these symptoms affect and how to diagnose them. How do we diagnose them? One of the ways that's easy to measure, that is great both before initiating a dopamine blocking medication, as well as every 6 months thereafter, is going to be the AIMS, or the Abnormal Involuntary Movement Scale. From there, we took a dive into the cell. We looked at physiology. We looked at functional anatomy, underlying those drug-induced and drug-exacerbated movement disorders. And finally, I left you with a bit of hope. I talked about those VMAT2 inhibitors in the treatment of tardive dyskinesia, and we're contrasting those VMAT2 inhibitors from everything we were using before for our acute dyskinesias, but most of all, from, again, what I learned in residency, which wasn't that long ago, that we have no treatment for tardive dyskinesia, which is no longer the case. We have got level A evidence for at least 2 great treatments that can affect this. So as we're putting all this together, this is being prepared, of course, this recording for a weekend conference. So you might have been ready, getting jazzed, getting ready, kind of dancing into your weekend conference. And I'm thinking about how you might have left work on Friday, as well as perhaps how you might show up on Monday. But like any weekend conference, the challenge here, what I want to challenge each of you who are listening to this talk to think about is what tools, what observations, what resources are you going to have for your patients now that you are experts in acute and tardive dyskinesias, as well as ways to address them. I have some references, and it has been an absolute pleasure for me to talk with you about this thriller review and update of extrapyramidal symptoms for 2021. I hope you have a great rest of your conference. Thank you for the invitation to be a part of your presentations.